A very good morning to Mr. here and the team from Hpsf. Just want to take this opportunity to say thank you for inviting me to give a presentation in your oral update. My name is Dr. Leong. I'm from Hospital Segamat. Today I'll be speaking on the topic of approach to Stridor. I think when people hear about Stridor, sometimes they feel fearful because in their mind, oh, this patient is having respiratory distress. So hopefully today, after this small talk, I'll be able to clear some mindset and maybe just help you all to be more calm when you approach the patient who has Stridor. So without further ado, let's get into the slide. These are my outlines for today. We'll talk briefly about what is Stridor, types of Stridor, and most importantly, how do we approach it, the differential diagnosis, and show you some videos and my take-home message for today. So my introduction for today. So what is Stridor? As some of you might know, Stridor is actually an abnormal high-pitched sound produced by turbulent airflow through a partially obstructed upper airway. And in ENT, we can also differentiate between Stridor and Stridor. Stridor is from the Latin term stridere, or to snore. Basically, it's a low-pitched sound. It's caused by partially obstruction of the upper airways at the level of pharynx and nasopharynx. And it's always inspiratory. And finally, wheezing. Wheezing is a high-pitched whistling sound made while you breathe. It's heard most clearly when you exhale. Some people might say that it's actually bronchi, but as long as you hear a high-pitched whistling sound on expiration, it is known as wheezing. So next is type of Stridor, which we know that the Stridor are divided into inspiratory, biphasic, and expiratory Stridor based on level of obstruction. So for inspiratory Stridor, we always usually see that there is an obstruction at the level of pharynx in the supraglottis, whereas in biphasic, it's usually at the level of glottis, subglottis, and up to the cervical trachea. Whereas expiratory Stridor, we usually implies that there is an obstruction at the tracheobronchial region or at the thoracic trachea region. So this is very important regarding Stridor. There is a difference between an infant and also an adult. So as you can see from this diagram, in an infant, a normal size of the trachea is usually about 4 mm, whereas in an adult it's around 8 mm. What happens if there is an edema of 1 millimeter? As you can see, because the size of an infant trachea is smaller comparatively to the adult, an increase in 1 mm will cause a reduce in the cross-sectional area of 75% comparatively to an adult, which is 44%. Hence, a pediatric patient will suffer faster comparatively to an adult patient. So this is why you see a patient who in pediatric age, they will have a lot of usage of accessory muscle if there is an edema, or the patient will usually collapse faster comparatively to an adult. So how do we approach it? Most importantly, it always comes back to what we learn in medical school: history, history, and history. So first, we have to know what's the age of onset, whether it's congenital or acquired, whether it is from birth or few weeks after birth, or is it something that is post-intubation, maybe a patient came in with MVA or trauma. Basically, is it acute or chronic? How long is the Stridor? Whether it's something that happened just today or something that has been progressively worsening for a few months. Whether there's fever or not, this is important to know whether it's infection origin or not. The severity, whether patient is in respiratory distress or is the patient stable. And the timing, is it during feed, positional? This is usually more for children. So these are a few differential diagnoses for us to be able to come out when we see a patient with Stridor. So as what we always learn, what is common is usually common for our patient. So it's easier for you all. I just list out a few things out of the exhaustive list of Stridor for a patient who who is neonate, basically few days old or few weeks old. The most common thing that we are known for stridor for children in this age group are laryngomalacia, subglottic stenosis, vocal cord paralysis, subglottic hemangioma, or even cysts. In children, we think of croup, supraglottitis, acute laryngitis. This is important for foreign body, as a lot of children picks up things and put into their mouth inadvertently. And most importantly, retropharyngeal abscess is also quite common in pediatric age group, and also rare, but we can get a few of these cases are respiratory papillomatosis. And in adult, usually patient will have common causes are laryngeal carcinoma, laryngeal trauma, supraglottitis, or acute laryngitis. So in this picture over here, you can see snoring for due to adenoids where you can get Stridor. Stridor in kids, maybe again like I say laryngomalacia, vocal cord palsy, subglottic stenosis, whereas in respiratory stridor, wheezing, you'll get foreign body, tracheomalacia, vascular ring. So do remember these few things, and when you see patient, these are the common things that might come into your mind. Okay, so next. So this is just a flow chart to tell us to make it easier for us to think of. As usual, when you get a patient with noisy breathing, we just have to differentiate between stertor and stridor. Most common cause is for stertor for pediatric age group is actually either tonsillar hypertrophy, or maybe patient might have some tonsillar hypertrophy, microglossia or micronaptia, or in some cases choana atresia as well. In stridor, you again, like we said earlier, we have to differentiate between inspiratory or biphasic or expiratory, and from there we have to again differentiate whether the normal voice or hoarse, patient is it afebrile or febrile, to again look for whether is it infectious in origin or not infectious in origin, and for that we can able to differentiate. It makes things easier to different to zoom in to what we want to treat or to diagnose the patient in. Okay, next. Okay, the next slide, to stress or not to stress. When you see a patient who is stridor, always remember, do not panic. If you are panicked, we will not be able to do what we are supposed to do, and your mind gets messed up. So remember, when you see a patient with stridor, take a deep breath, do not panic, and always go back to basic, the ABC. Airway is it okay, breathing is okay, circulation is okay. If all these things is okay, then we can continue our examination of the patient, ask for further history. Think of, like we said earlier, is it something acute? Is patient having fever or not? Is there any associated neck swelling to help us in our differential diagnosis? If the patient is in distress, then consider oxygenation, or even intubation in certain cases if you think the patient is already in an impending collapse, especially in pediatric patient. Do not hesitate to call for backup as well if you are in a ED setting where for pediatric case, call for the pediatrician to come along to help you, or even inform us so that we are able to come to help in whatever ways that we can. Next, after you have taken all the history and the patient is stable, we can proceed with blood investigation. Patient who came in febrile and having stridor, remember to take FPC, poor take RP will do, and once the patient is stable, you can always send for imaging to check what is the cause of stridor, especially in a patient who is febrile. They can check X-ray or CT scan, whichever your centers allow. In chest X-ray for a patient who is in pediatrics population with fever, two common findings you can see. One is a steeper sign. This is in the first picture on your left, on my left. Then is a second picture on your right. Above is a typical picture of epiglottitis, a thumb sign. And CT scan sagittal view below shows a retropharyngeal abscess. So as you will be wondering, what do ENT do when you all refer to us? So basically, we will do something called a flexible scope or 70-degree scope, which is used to check is there any pathology, most importantly at the level of larynx. So as you can see in this video, which I'm going to show later, this is actually your vocal cord over here. Anteriorly, this is your epiglottis, this is your arytenoid, and at the side here, this is your piriform sinus. And you will see this is what we call the false cord. This is the true cord. So this is a patient, 62 years old female lady, which was referred to us for biphasic stridor from the emergency department. Upon examination, patient is able to maintain oxygenation under room air, and there is actually a history of intubation 1 month ago. We brought the patient to our clinic and we did a bedside tracheoscope. So basically we injected LA into the trachea, and we proceeded with a flexible scope. So as you can see, we are passing through the vocal cord. The vocal cord here is mobile. This is your subglottic region. And as you can see, we go in. You can see there is a matured scar here. This is what we call a tracheostenosis. With only a cotton layer grade 3, a small opening here. So this patient was then subsequently referred to UKM, and they did a trachea dilation for this patient. So the next slide that I'm going to show you, this is actually a 9-day-old child, born term, was referred to us for stridor and also difficulty in bringing down oxygen from the pediatric team. So what we did was we did a flexible scope bedside, and as you can see over here, there is actually a mass arising from the false cord. Okay, and we then was thinking in our mind, what is this? And we had a differential diagnosis of laryngocele, and we proceeded to do a CT scan, and the CT scan did confirm the diagnosis. This case was then discussed with our consultant pediatrics ORL. We then brought the patient into OT to do airway assessment for this child, and after the operation we decided that the best way forward for this child was actually to just treat conservative and to repeat the scope in 6 weeks, because there wasn't any obvious mass seen intraoperatively. Okay, the next slide. Hope that you all are doing well. Just bear with me for another 3 more slides and we are done. I'm going to show you another case. This is a day 30 of life, born term, was referred to us by the, again, pediatrician, because they noted stridor and they are unable to win off oxygenation for the child, and the child has been having poor weight gain. So we did a basic scope for this baby, and again we noted for this child a typical laryngomalacia feature, which was a short AE4, some fluffy arytenoid, as you can see, and then the epiglottis was okay, omega shape, but it wasn't flopping in during inspiratory. So we proceeded to do examination under anesthesia, and also we planned for a supraglottoplasty, as we were treating this child for severe laryngomalacia. So what we are doing here is, as you can see, DL scope was done, and this is actually a tracheoscope. We were looking for if there any sign of tracheomalacia for this patient, and after that we inserted a ETT tube, and as you can see here, this is the AE4, and it's actually very tense, and this is what we do in supraglottoplasty. As you can see, we are going to do a small nick at this AE4, this band. We first cut it using a cold instrument, and subsequently what we use is a diatomy to just release the band for this patient. This is on the right side. This is the epiglottis, so this is anterior, this is the posterior part. So this, using a diatomy, we proceeded to release the band, so this will lengthen the AE4. And this is the end product of the surgery, the supraglottoplasty. So this baby was subsequently well, and thankfully she was able to be discharged just today on this day where I recorded this slide, and the word gain has been well for this baby. So we will then follow up this patient subsequently in our clinic. Okay, the next slide. You can see there's two pictures that I posted here. The picture on the left shows a mass that seems to be arising from the subglottic initially when we saw the patient in the clinic. Subsequently, we brought this patient into OT. We did a DL scope and noted actually the mass is arising from the undersurface of the right glottis. This is your glottis, your true cord. We did a biopsy, we removed the mass completely, and unfortunately for the patient, it turned out to be CA larynx stage 1. So this patient was then sent to another tertiary center for further management. Whereas for this patient on this picture on the right, unfortunately for this patient, this is what we typically get for a lot of patients who have CA larynx. When they come to us, there is already a big mass that's arising from the right side of the glottis. This is from the supraglottic area. We are thinking that it's already invaded to the glottis. We brought this patient to OT, took biopsy, and we even did a tracheostomy for this patient because there was already a sign of airway compromise for this patient. So next, when the result came back, the patient was confirmed to have CA larynx. We took after consultation with the patient, we decided to do a total laryngectomy and also a neck dissection for this patient. After operation 1 month, currently the patient is awaiting for his CCRT at HSIJB. So finally, come to treatment. So after all the slides, all the video that I've shown you, so again, definite treatment is again based on the diagnosis of the patient as usual. It can be as simple as an observation for mild laryngomalacia to surgery for the patient that I showed you just now for severe laryngomalacia where we need to do some intervention, especially for child who has poor weight gain or in respiratory distress. Incision and drainage for abscesses for anything from paropharyngeal abscess to retropharyngeal abscess. In patient who has bilateral vocal cord palsy with airway compromise or subglottic or tracheostenosis, tracheostomy can be done for treatment to alleviate the respiratory distress, and even for patient with tumor, especially for CA larynx, laryngectomy can be done for a patient. So my take-home message for today, whenever you come across patient with Stridor, especially those who are in district hospital, or maybe next time you will be sent out to somewhere where there is no ENT backup. Remember to always relax, take a breather, and go through the ABC. If the patient is stable, continue to find the cause, take history. Patient is it acute or something that has been going on for some time, and formulate a diagnosis in your mind. If there's no immediate intervention and you think that there's need to refer to us, always feel free to refer to us. We will see the patient and we will take on from there and do what is necessary and give the appropriate treatment. So I just want to thank you for this opportunity. I hope that through this talk, you all will be able to just relax when you see a patient with Stridor. Don't have to be so stressed. And always remember, especially if you're in a tertiary hospital, there's always backup. Always call for help if you're unable to handle the situation. And just know that we in the ORL team is always there to help you guys. So thank you.